as someone who has great experience in CAR-T and bispecifics, Rahul, your thoughts about how we integrate, for example, both iber and mezigdomide with these important immunotherapies?
Yeah, so I think ask me again in 2 years or even 1 year, right? This field is rapidly evolving, but I think the synergy potential is fantastic. As all of us have alluded to, I would argue that these CELMoDs should be known not just for their powerful anti-myeloma effects, but really for their T-cell effects in terms of reducing T-cell dysfunction. So I know we're participating in an alliance study of post-ide-cel ibertamide, just as an example, of using. I'm not thrilled about the idea of post-CAR-T maintenance, but some patients need it. We know that CAR-T does not seal the deal for patients, and if you find a drug that's well tolerated, like a CELMoD, that may be what you need to keep those patients in remission. There are studies of post-CAR-T mezigdomide as well. There are studies of combining a bispecific antibody with iber or mezi. I think Meletios A with elra-iber has shown really impressive data. And then you alluded to the STOMP cohort of celi-mezi-dex. So selinexor obviously is also, as you alluded to, is both a novel class of medication in its own right, but also has these T-cell effects. And so the two of them, I think, will be very helpful as a rehab for T-cells. So we're asking a lot of our patients T-cells, and sometimes the T-cells are just exhausted, burnt out, dysfunctional, and I think these drugs will be very helpful even for the patients who don't have a duration of response exceeding 2 or 3 years. I've had patients where I've put them on celi-mezi-dex and it holds the line for 6-8 months, and then if it stops working, by this point, their T-cells are ready to be re-engaged.
Yeah, it's very interesting because I completely agree with you about the mezi-celi platform, which I've been very pleased with. I think I have a patient, an example, who I was teeing up for CAR-T, and he did so well on mezi-celi. He's actually now almost 2.5 years in,
Amazing.
and he's just saying, no thanks, I'm going to keep my CAR-T in reserve. I'm doing just fine on my mezi-celi. So to your point, so thank you for sharing that. Actually, that's very important. So as a person who's an expert in antibody-drug conjugates, Katja, please can you share with me obviously you're presenting data, or your study group are presenting data both here at ASCO here at ASCO, my apologies. You already presented at ASCO the DREAM9 data. What about the combinations of mezigdomide with antibody-drug conjugates? What promise do you see for that?
I think it may be very striking, as we saw great data on the belamaf Pomdex combination in the phase 3 trial, respective trial, and we see, especially in front line, we now show data from the DREAM9 study investigating the combination of belamaf with a VRD backbone in newly diagnosed transplant non-eligible patients, that the introduction of the anti-BCMA agent in this context leads to very rapid and very deep remissions, and this is what brings the patients, especially with high tumor burden and suffering from the symptoms of myeloma, in a very short time back, reducing pain, bringing patients back to normal life or nearly normal life. And I think the better we can optimize the backbone, combining that with anti-BCMA strategies, even better are the long-term responses, because the early achievement of MRD negative remission prevents from the development of early resistant clones, clonal escape, and all those features, especially patients with high-risk disease and high tumor burden suffer from. So I think there are many opportunities to move on also with those combinations.
So got it. So if I may just drill down on it a bit, if you were to think about, because there is actually just one investigator-sponsored study right now in France looking at mezigdomide and Bela, which is specifically addressing those patients in whom a prior BCMA strategy has failed them. As you think to the future with mezi and, say, for example, belantamab mafodotin, where would you love to see it first used? Would you like to see it used earlier in that context?
I'm not sure. I think the field is moving so dynamic, so fast. We have to see definitely more data or more mature data, to my opinion. And there will be always, I think, a situation, patient population where things fit, and I think this enables us to come to more and better tailored strategies, also addressing myeloma and addressing the individual needs and the individual biology.
Well, because honestly, what I was thinking really of was, we've all four of us been at the IMWG meeting, which is such a fantastic meeting every year. It's probably in my opinion, it's the highlight of the year in so many respects. But there we were discussing this whole concept of equity and access, right? And I was talking with Brazilian colleagues, and obviously in Brazil, a platform like mezigdomide, with belantamab mafodotin would just hit that sweet spot potentially of real utility with minimal infection rates and the complications that would be so challenging in other healthcare jurisdictions that we're, can fortunately manage ourselves to a greater degree being avoided. So I personally agree with you. I just think the opportunity for really leveraging all that's best about immunotherapy lies in the possibility that Mezi is, as we've said to each other, and I say this very carefully, CAR-T in a pill, but I would say that in the context of combining it with other strategies, we bring the best of both together. So thank you, Katja, for that thoughtful insight. If I may, I'm going to ask you to wrap this.